screening program, like in Japan. Okay, that's very important. So otherwise, also you suspect and you don't have anything to investigation, so you can go for a stool to see for occult blood, and that might give some idea whether the patient has got colon carcinoma or not. You can see all this type of lesions of colon carcinoma. These strictures, these are all strictures. This ulcerative type. These are all also proliferative type of the colon carcinoma specimen. And if you see in X-ray, double contrast, you see these are the normal. These are proximal dilated because there is obstruction. This is a lesion like this, okay, and this also there is a strictures like this, and there is a lesion, and this and proximally they distended. Distal is a slightly not distended, okay, and you can see this is not a shouldering. This is like a neck, okay, and this is like a shoulder, because as if the shoulder and neck. This is all known as shouldering of the lesion of the colon carcinoma. Okay. This is what you can see in double contrast, and you can see the known walls has apple core. If you cut the apple in the center, you can see this type of lesion. That's the apple core appearance of the colon also. You know, that's a typical feature of malignancy, any tubular structure in the body. So, investigations, fecal occult test as a sort sigma ratio colonoscopy of barium anemia or CETB or virtual endoscopy. These are the very screening tests they do in developing countries. And treatment definitely is surgery. Now, and just to understand, if you can remember things, is okay. Treatment has got there are different modalities of treatment, like surgery, chemotherapy, or other non-surgical therapies are there. But when to go for straight for surgery, or when to start pre-operative chemotherapy, when to do your pre-operative chemo radiation therapy, then surgery, or surgery, then chemotherapy and radiotherapy, that's a matter of debate and experience. Okay, but surgery is the mainstay, depending on the site and the stage of the lesion, which can be curable or not. Okay, so in the right side, one might go for a hemicolectomy. Okay, transverse colon extended hemicolectomy or transverse colectomy with both the hepatic and ischemic fracture. Left side throat, you go left hemicolectomy. Even then, sometimes if there is single lymph node in the secondary in the liver, might go for segmental hepatectomy and remove the what you call the secondary from the liver, as well as along with the colon carcinoma. So the diagrams, if their lesional the malignancies are there in this particular region or upper right side, or in transverse colon, or upper left side, or in sigma rectal sigma junction. So these diagrams give you that much a portion of remove anastomos. Okay, this surgery in colon carcinoma usually you can find in some of the books also. Then, as I told you, there are two more modalities of treatment: chemotherapy and radiotherapy. So, if the patient can't be what you call treated and it's so extensive that you can't do a surgery, then probably to reduce the size of the tumor, you can go for what you call either chemotherapy or radiotherapy. So, indicated chemotherapy is positive lymph node, T4 lesions, venous spread, a signet cell type of lesions, a poorly differentiated tumor, high CA level, you go for chemotherapy, and you see if they improve, then you go for surgery. Same thing with radiotherapy, you give pre-operative radiotherapy. If you can reduce the size and you make it operable, then go for surgery. Or just you can operate for the palliative therapy, you can go for chemotherapy or radiotherapy also. I come to rectal carcinoma, second most common cancer, more common in existing papillomas. As I told you, even in a colon carcinoma, the endocarcinoma sequence has got a role on this existing papillomas, adenomas, or adenomas polyposis, hereditary polyposis, whatever it is. Very common that they have got uh, the affinity or most important on the papilloma. So it occurs in multiple sites. Okay? That, same at the same time, and they might develop in different time. It's metachronous in rest of the time. They might develop. So when you see one lesion, you must go and find if there are other lesions further ahead or not. That's very important. So risk factors, as I said, diet, all sides, or this heavily polyposis or uh, uh, ulcerative colitis and Crohn's disease. They are the risk factors. And types, grossly, as I told you, this ulcerative, proliferative, inflammatory, annular, diffuse, histopathically well differentiated, modular differentiated, or undifferentiated, whereas modular diffuse are very high, 65%. So these are dependent upon the cellular ATPR, and they spread circumferentially. I told you it takes 12 to 18 months to complete a whole circle. So if you see the lesions and see how much of circumference has involved, you can predict the age of that tumor. Or there might be submucous mucosal involvement, mesorectomy involved, pericolic, prostate, bladder, uterus, vaginal, sacral plexus might be involved, nearby structures. They might be spread by lymphatics or paravertical or rectal. So below the peritoneal reflections in inguinal lymph node. If you see the rectum has got reflections, almost lower part is extraperitoneal and the upper part are intraperitoneal. So that's why depending on that lymphatic drainage is spread even in the lymph node inguinal region. So they might reach up to the lungs or the adrenals or liver through venous spread or peritoneal spread and peritoneal dissemination directly or through the lymphatics. Okay, the dukes and modified dukes and clear calcium are almost same as in the colony carcinoma. So the most important thing is painless, bright red bleeding. That is very common in even hemorrhoids, but especially in also in the rectal carcinoma, this is very common. So any conditions where there is or bleeding, bright red bleeding per rectum, you must think of colon carcinoma, and you definitely put your finger, do PR, and see if there is a lesion or not, or you go for proctoscopy, even cystoscopy, you can do in outdoor basis and see if there is a lesion or not. So you have to differentiate from hemorrhoids and colon carcinoma very well. So there will be tenesmus, incomplete evacuations, or painful and unable to pass the stool. There might be spurious diarrhea, early mucus, morning mucus, blood flatus passing per rectum, or there might be alteration in bowel habits, defecations with loose anemia because of blood loss. There might be in bladder because of urinary symptoms, injury in the back, so backache, ascites, weight loss, abdominal pain, and liver mets. So these might be the presenting factors of rectal carcinoma. As I said, direct rectal examination is very important. They said if you don't indicate it, then you might have to put your foot in the rectum. That's why it's very important, simple, no time consuming, no cost consuming. It's rectal examination. Then you go for enema or biopsies, then ultrasound, CCT, MRI, this type of lesions, and it's spread inside the abdominal cavity, and all CA and all hemoglobin and all blood pictures that might give some idea of the carcinoma. And you have to differentiate, as I said, most important with the hemorrhoids, then fistula, maybe granuloma, solitary rectal ulcers, inflammatory bowel diseases, carcinoma tumors, or endometriosis. Every condition where there are what you call pain abdomen with bleeding, painless or painful bleeding, is has to be differentiated with the rectal carcinoma. And treatment, as I said, depends on size, stage, histology, differentiation, anatomical factor, and distance metastasis, as in the colon carcinoma. So radical excision of rectum, mesorectum lymph nodes is very important, and preserve the continence. The most important thing that in this surgery, you have to maintain the what you call continence. If somebody has can't be preserved the continence, then you will have a very disturbed life because they are go to ileostomy or colostomy whole life. That's a very disturbing in the life. And if you can operate, so you have to maintain the continence. You have to go into luminal stenting, or you might go for chemoradiation therapy or palliative surgery in those cases where you can't cure the disease. Okay. Treatment, as I said, there are different treatments: palliative colostomy or abdominal peritoneal resections, or just ileostomy or anti-resection and colorectal anastomosis, pelvic excentrations, or TATME, transanal total mesorectal excision. This is a new modality. They pass a scope from the anus and go to the peritoneum and excise the whole lesion and come out, and they may maintain the rectoanal anastomosis. So this is what a new modality is. You can just find in your YouTube. The last is anal carcinoma, in stage 2% in last bowel, and it's always below the dentate line, the 80% of squamous cell carcinoma. Basaloid carcinoma above dentate line. The cause is the hematopapilovirus or HIV infections, or any intraepithelial neoplasm, or those who are immunocompromised patients or immunosuppressed patients in organ transplant. It could be or squamous cell, basaloid, or mucoepidermoid carcinoma, basal cell carcinoma. Melanoma is very important. They are hiding in the anal crypts, so that's very important. And adenocarcinoma. These are the types of carcinoma, anal carcinoma, and they might present with ulceration and bleeding, uveitis because of discharge, irregular growth, vaginal fistula sometimes, or fecal incontinence because of loss of tone of the anal canal, and there might be a hard inguinal lymph node because they drain in inguinal region because they are below the peritoneal reflexes. Because of obstruction, there might be constipations. Then the same thing that you do PRC and you go for FNAC or biopsy. Then you go for ultrasound for any disseminations. Then you can go for MRI. These are all the same classifications of TNM. TIS in situ, T1 is more less than 2 centimeter, T2 2 to 5 centimeter, T3 more than 5 centimeter, and T4 invasion near organ. And N1 perirectal lymph nodes, N2 unilateral intrarenal internal lymph nodes, then M1, M0 is no metastasis, M1 is distant metastasis. These are TNM classification anal carcinoma. Wide excision of the growth with block dissection followed by radiotherapy is the treatment of anal cancer. And the Negro regime is initial radiotherapy, then followed by chemotherapy. Then you go for surgery, the abdominal peritoneal resections after 3 weeks. That's a Negro regime that is usually done for the anal canal carcinoma. So this is how this colorectal anal disease carcinoma is what called presents, and almost they have got same pathology and same oral presentation and what we call the presentation and investigation and treatment part. Okay.
Excuse me, sir.
Yeah.
सर जस्तो ग्यास्ट्रिक कार्सिनोमामा लिम्फ नोड रिसेक्सन मोडालिटी छ नि D1 रिसेक्सन D2 रिसेक्सन भनेर त्यस्तो छैन यो रेक्टलको केसमा चाहिँ
अहिलेसम्म एक्चुअली दे आर नट द्याट बिग अमाउन्ट अफ लिम्फ नोड्स अराउन्ड द कोलन. They have got paracolic. They are not named, but they are named by the vessels along with them. And the 3 group. So in the paracolic, just in the border of the colon, and in between the IVC or aorta, that is central group, and in between there are few. So level 1, level 2, level 3, paracolic, intermediate, or central lymph nodes there, but they don't have that type of number like in gastric carcinoma or neck lymph nodes. They have numbered. They have not numbered because it is very wide sort of what you call vascularity, and they have got a, what you call the wave of lymphatics. They cross each other, so it is very difficult to identify like in gastric carcinoma. That's a different, but it's a good question. Okay. Anybody?
Oh, thank you, sir.
Okay then. Be safe and see you again next week.